That was your fair warning. Welcome everybody to tonight's, I'm sorry, I'm on East Coast time, to this afternoon's webinar on sexual health and recovery, part 1. So as you may have noticed when you received the announcement for this webinar, it is a 2-parter. So this afternoon, we're going to cover mostly kind of some introductory material to what we mean when we talk about sexual health, and how it fits into and how we can make sure that we pay attention to it as part of the recovery process for individuals that we may be serving who have serious psychiatric conditions. And so we'll cover a lot of the challenges that individuals with psychiatric conditions face in terms of sexual health, and how that's kind of a bidirectional relationship as well, in terms of how improved mental health assists with improved sexual health and vice versa. So we're going to dive into that in a moment. My name is Dawn Reinhardt Wood, and I'm one of the faculty at Rutgers University in the Department of Psychiatric Rehabilitation and Counseling Professions here in New Jersey. And I work in an embedded, we call it embedded, but primarily in an embedded consultant role to the New Jersey State Psychiatric Hospitals, in implementing, researching, and training around evidence-based psychiatric rehabilitation and related practices for the individuals that we serve here in New Jersey at our highest level of care. I also worked in supportive housing for about 17 years and ran a couple of supportive housing and homeless outreach programs before I came to Rutgers. So you are my people, and I love spending time with you. And I recognize what a difficult job that you all do have. So just some housekeeping items before we get started. I want to welcome you again, and today's webinar is hosted by DBHR through the Healthcare Authority. This is an interactive training, so I encourage you to ask questions and interact with me as much as you'd like throughout the session. One thing I will say about this session, usually if you've attended any of our webinars in the past, you notice we usually tag team and have 2 facilitators because of the time of day on the East Coast here. That was a little bit more difficult for this afternoon's webinar. So we also are really busy. This is you wouldn't think that after the semester is a very busy time of year at a university, but it tends to be. We only have a couple weeks to prep for the new summer semester. So you only have me today. And so with that being said, please be patient with me in terms of if you ask a question in the comments. It might take me a little bit to get to that question or comment. I am going to pause and try and look at the chat window every so often, but just so you know, when we're in presenter mode, that's a little bit more difficult and clunky. So please do know that I will take a look. And if you feel like I've ignored your question, please feel free to send it in there's a Q&A option in Zoom, which will kind of isolate that question for you. And it's an area that I can go to and just see a list of questions. So you should have that option in your toolbar for Zoom. So the slides, as well as a link to the recording of the webinar, will be made available to everyone who is registered in a follow-up email that will be sent after the presentation. Because of the time of day here on the East Coast, you'll probably get that email tomorrow. So for now, everyone is muted and cameras are off. If you'd like to ask a question, again, go ahead and put it in the chat, or you can use that Q&A option, and I'll call on you as I can get to those questions. I'm also going to try to leave a little bit of time towards the end. Usually I like to answer questions and take comments and have dialogue throughout the course of the training, but because of the situation today, I may just kind of stop a little earlier, and then we can open it up for questions and comments and any that I may have missed towards the end. I know that there wasn't an end time that was sent out with the email. That was an error on our part, so I apologize for that. But this will probably last about an hour and a half, just so you know, because I know you all have a lot of things to do. And this is me with one of my different many colors of hair pre-pandemic. So again, I gave you my spiel. In addition to having history and working in supportive housing and homeless outreach and screening and crisis services, I've also done a lot of disaster response work, and that's been pretty much the most rewarding part of my career, has been providing disaster response crisis counseling in the aftermath of man-made and natural disasters. So why don't we go ahead and get started? I'm going to briefly cover what we hope to convey, or what I hope you'll be able to take away from today's webinar. So I'm hoping that by the time we wrap up today, you know, none of us are going to be sexologists or sex therapists, and that's quite all right. I am not. This just happens to be my area of study and research for my dissertation, and moving forward, this is my area of interest, where that intersection of sexual health and psychiatric conditions exist. So also to that point, I want to say, especially, this is probably especially important for part 2. I am a cisgender heterosexual female. So, and I am still learning and growing, and I have a lot of curiosity about continuing to learn about sexual health, and today is the start of Pride Month. And so I just also want to recognize that, and to say that if I misspeak, if I use any terminology that you want to correct, you feel that there are better ways to say things, I absolutely love that feedback, because it only makes me a better teacher, clinician, and human being. So I appreciate any and all feedback, constructive feedback. So getting back to our learning objectives, by the end of this webinar, I hope that you'll be able to define sexual health. And when I say define sexual health, I really mean looking at it as the multifaceted concept that it is. It's not just about the physical act of sex and any kind of disease processes or illnesses that may arise related to reproductive and sexual health. So it goes way beyond that. We're going to discuss the impact of stigma on sexual health and wellness. So I'm sure that individuals that you work with, and any individuals that we may have participating today, myself included, as someone who is a recipient of mental health services myself, knows that stigma can play a huge role in folks reaching out for assistance, getting early intervention in any kind of processes or diseases or conditions that they may have that have been stigmatized or associated with a group of individuals that may be stigmatized among our population. We know individuals with mental health conditions have definitely been stigmatized and continue to be. And then we have individuals who have other personal characteristics about them that may also cause them to incur stigmatization and this feeling of like lost identity and over-identification with, you know, psychiatric conditions and other illnesses or risk factors that they may possess. We're going to talk about sexual health risks for people who have behavioral health conditions that exceed, or in some cases far exceed, the general population. And we will begin to talk about some initial strategies for supporting the sexual health of the individuals that you may work with. Again, reminding everyone, you know, we're not going to be experts in all things sexual health, even after part 2 of this, but I really hope it's just an introduction and a primer for learning more if you so choose. And I'm really sorry, but our pollen count is extremely high. the last few days here on the East Coast, so I'm suffering terribly from allergies. So I will be drinking a lot of water to try to treat my froggy voice. So I apologize if I have to do that. Okay, with that said, let me take a sip. So I'm actually going to take a step back here. I wanted to hear from all of you, maybe not all of you, but as many of you as want to participate. When you think about sex, sexual health, intimate relationships, whatever terminology kind of makes sense for you right now, what are some of the benefits that you can think of? And if you want to think about your own positive, and I'm going to emphasize positive, and when we talk about intimacy and the benefits that we get from intimacy, especially tonight or today, we'll be talking about physical intimacy, which may or may not include sex as an activity. I want you to think of those positive experiences that you may have had. If you have not had any, that's okay too. But if you had, I want you to think about what are some positive benefits of sexual relationships, sexually intimate relationships that you could imagine people may gain. You'll see on the next slide there, I had my top 3 that I could think of for my positive intimate relationships. So if you just want to type in the chat, what are some of the benefits that you can think of that you feel are attributed to having positive sexual health and positive sexual experiences in one's life? So I'm going to open up the chat and take a look and see if anyone's typing. I'm just going to kind of leave that open for a minute or so. If we don't get anybody at this point, that's okay. Yeah, so we had someone and they sent it to just the host. So I'm not going to say their name because maybe they wanted to keep it private. And so for all of you, when you're typing in the chat box, make sure that you have your little next to the 2, you have selected everyone if you want everyone to see it. If not, you can send it directly to me. That's fine. Yeah, so I'm seeing a lot of great responses and diverse responses, but confidence, closeness to a partner or partners, fun, right? Fun is a good thing. That was in the private message. Intimacy, feeling wanted, connectedness. Yeah, that's very close to that closeness, close to closeness, right? Serotonin, yes, and a feeling of wellness. Trust, safety, I love it. So yeah, and in connection to that comment about serotonin, not only do we release serotonin during sex, but also upon and after orgasm, individuals also experience a release of something called oxytocin. And oxytocin, I'm going to type it in the chat. Oxytocin is another hormone, a chemical, a naturally occurring chemical in our body that's a feel-good hormone, very similar. Serotonin helps to boost our mood and also kind of stabilize our mood. And that's really closely related to deficits in serotonin in some cases are related to some types of some depression. I shouldn't say some. The manifestation of depression in some people. And so oxytocin is a similar type of hormone, but it does something a little different. So oxytocin is a bonding hormone. And so the idea around oxytocin, it is also a chemical that is released when you're around babies, when you're around your children, albeit when your children are behaving. I have a 15-year-old boy, so I'm not sure how much the oxytocin is released in me anymore. A lot of times it seems to be some hormone that's raising my blood pressure, but I'm sure when he was little and cute and kind of stayed in one place and didn't talk back to me, a whole lot of oxytocin was released. So these are great. Yeah, and trust and safety, I love it. So again, that feeling of like connectedness and somebody having your back. So I love these comments. So I'm going to go to what I figured, like, let me just think of 3 for me. So for me, when I thought about it initially, just about the sexual part, I had more of those feel-good hormone things and that sense of closeness, desire. And then as I started to learn more about sexual health in general and how it relates to our overall wellness, and for those of us who may be recovering from a mental health condition, and for those who may have a mental health condition that is recurring or longer term, like recurrent depression or schizophrenia or bipolar disorder, these can be long-term conditions that we have to manage over time. And so when I started to think about that, I started thinking, well, if I'm thinking about an intimate relationship, especially one that may be monogamous, I start to think of those things that I think a lot of you said around bonding and closeness. And so to me, it was that development or the enrichment and reinforcement of love, which happens through that oxytocin. See, when you're in science, you always relate things back to chemicals, kind of loses some of the romance, but I tend to do that. So that oxytocin release, it's a reinforcer of those feelings that you may have for that other person, and hopefully that they have for you. Support, right? So as we continue to bond and become closer, we have another individual who, as we said earlier, might have our back, we hope, to support us emotionally and physically, spiritually, in a multitude of ways. And also growth. So developing that relationship in one that I don't know about many of you, but to me, the excitement about having a really good partner, or a partner that's a good fit for you, I'll say, is that, future forward, looking at things together, towards the future, and being able to build that. I always say to my fiance, building the empire. So being able to build that empire that you want. So you see here, like, not a whole lot that explicitly deals with sex. So as we start to get into this discussion of sexual health, you may ultimately add some things to your list or take some things off, but typically these are the things that I think of. Again, may not be the same for you. So the World Health Organization generally defines a succinct definition of sexual health. Excuse me, I shouldn't say a succinct definition, a succinct description of sexual health is that it is fundamental to our overall health and well-being or wellness of individuals, couples, and families, and to the social and economic development of communities and countries. So I want you to think about this statement and reflect on it for a moment. Why do you think that sexual health, or why do you think the World Health Organization would make this statement that sexual health is directly related to not just one zone, their partners, their families' well-being, but to the social and economic development of communities and countries? How would the sexual health of a population, do you think, connect with social and economic development? Anyone willing to take a stab at that is welcome. I usually don't have a lot of takers on that question. So I'm going to take a look at the chat, see if anybody contributes. Great, Carolyn, that's absolutely great. And that's where they're going with this. So thinking about overall functioning, think about areas in the world that were hit especially hard. We don't have to look too far back to a mass pandemic, right? To be able to see how when a population is afflicted by illness, disease, especially a serious illness or disease, potentially serious, as obviously COVID was and still is, how that affects the overall, in our case, with the pandemic over the last 3 years, the overall functioning and well-being of the entire world, right? That was a global experience. And when we consider other kind of global epidemics or even conditions that tend to be isolated to certain populations or geographic areas of our world, we can also see how those areas of the world can be affected, especially socially and economically. So when you think about places in the world, some places in Asia and in sub-Saharan Africa that have been, in some cases, multiple generations devastated by HIV and AIDS, you will also see that there is difficulty in growth in those populations, not just because of that illness, right? So these may be areas of the world that may be historically have lower socioeconomic development. But these areas that have been just kind of plagued by some of these conditions, especially over many, many, many years, we see decline in offspring. We see decline in, children that are born being able to grow to adulthood. So that starts to have a really devastating effect on a culture, on a community, on a nation, even. So if you don't have individuals who grow to adulthood who are able to work and contribute in that kind of functional way to a society, you will have economic and development problems within the society, not to mention the ways in which those conditions can ravage families at their core. And so when we think about that, when we think about how some of the sexually transmitted diseases or infections have really devastated certain communities, I want you to also think about that in terms of the individuals that we serve. So we're going to talk a little bit about the prevalence rates of individuals who have serious psychiatric conditions. And one of the things that we know is the rates of occurrence of sexually transmitted infections and unplanned or unintended pregnancies, interpartner or intimate partner violence, sexual assault is much higher in the population that we serve, right? So thinking about that population as kind of a subculture, and think about how those conditions can, really devastate the social development, the well-being, and the overall ability to function of some of the individuals that we may serve. So thank you for your contribution, Carolyn. So the World Health Organization goes on to say that the approach to sexual health requires a positive and a respectful approach to not just sexuality and sexual relationships, but as also to the possibility of having pleasurable and safe sexual experiences free of coercion, discrimination, and violence. And again, when, just kind of bringing it back to the individuals that we serve, they are at a greater risk of sexual exploitation, human trafficking, sexual assault, intimate partner violence, and having multiple experiences of that. In addition, the individuals that we serve are more likely to have other traumas aside from any kind of sexually related traumas. And we'll talk about how that can fit into the development of a healthy kind of sexual health status also, and the development of romantic and intimate relationships that may or may not include sex as a part of them. Okay. And one of the reasons why, despite our level of comfort in the topic of sexual health, despite our comfort with terminology and kind of the chemistry and biology and physiology beyond a lot of things, and also despite our discomfort that just talking about sexual health sometimes brings up. For me, I had to develop the tolerance to be able to, I call it distress tolerance, to be able to talk about it in front of other people if I wanted to research it, right? So I was perfectly comfortable kind of in my small group of other faculty at the university and at other universities that I have consulted with to talk about sexual health. But when you're talking about it to a broader audience, or maybe individuals that don't expect you to be talking to them about sexual health, which may be our supportive housing tenants, it can feel a little bit uncomfortable. Sometimes the uncomfortability is in not knowing what to expect in terms of the individual that you're talking to, right? And that tends to be my anxiety sometimes. And so, you can acknowledge that sometimes it may be a difficult conversation and that you may make mistakes, and that's okay. And it's okay to say that to the person that you're talking to. But what we want to do is bring this positive, respectful, and supportive approach, because as we know, in any of our interactions, if we want to build therapeutic rapport, that's the basis for everything. And furthermore, on that note, this is just a little tidbit that in several studies, individuals have rated the success of their therapy or treatment interventions higher, regardless of the type of treatment intervention or school of psychology or affiliation of their theoretical approach of their therapist or doctor. Those that feel they got the most out of going to therapy, out of going to mental health services, are those who rated the therapeutic relationship with their doctor or their prescriber or their therapist or their counselor, their supportive housing worker as high. So for those individuals who feel like their caseworker, their therapist has holds them in positive esteem and respects them, they tend to rate their services higher and feel like they were helped better. So, that's just to say, be nice to people. And I don't feel I need to say that to any of you, but I just like to emphasize that you don't need too many letters after your name to make a positive impact. Don't tell the doctors that, though. So let's talk a little bit about how sexual satisfaction, and when I say that, I just simply mean satisfaction with one's sexual health. Excuse me. How that sexual satisfaction in the global sense of sexual health and psychiatric recovery fit together. So one of the things that we know from research is that individuals who rate their satisfaction with their sexual health as high or higher tend to also rate their psychiatric recovery as more advanced, meaning they're a little further along in their recovery process. So this is probably an individual who feels like that they're either making progress or really starting to make progress on their goals. They have like a healthy image of themselves, healthy self-image. They don't see themselves as an illness. They see themselves as a person. And sometimes it's really hard to see in individuals who may be in some of the earlier stages of recovery. And so those individuals who rate themselves as further along in kind of like the further stages of recovery, nearing, remission of symptoms, or maybe even prior to remission of symptoms, also tend to rate their sexual health and their sexual lives as higher. Anybody want to take a guess as to why? Some of the clues are in some of the answers that you've already given in terms of some of the takeaways from positive sexual relationships and intimate relationships. I'll wait and see what you say. So we call this a bidirectional positive relationship. They travel together. All right, let's see what we got. Sure, absolutely, Sarah. So the question is, why do you think when we ask people, when we ask people, you know, how advanced do you think you are in your recovery process from a psychiatric condition, and how high or low would you rate your sexual health? Individuals who rate their sexual health as higher also tend to rate their recovery as more advanced, and vice versa. Individuals who rate their recovery as more advanced tend to rate their sexual health as more advanced or more satisfactory to them. Why do you think this is? I'm sorry, y'all. It's hot here today, and I didn't turn my air conditioning on. It's about 90, and I think it's about 95 in my apartment. Starting to get shiny. That's great, Victoria. So I would absolutely think that that's probably another, you know, that's definitely probably a factor. So having that other person, right, when somebody is kind of in those early stages of recovery, they may find it really, really hard to make connections with other people, right? Especially if part of their condition may be isolating, or maybe an inability to communicate or express themselves in a way that they typically would, you know, minus the symptoms. And that feeling of, you know, having that support, right? So having a support person. So let's see, Diana also said because they're feeling better about themselves in their future, right? And so, like, we don't really know if this is a chicken and an egg thing. and I like to think that they just kind of travel together. Sexual health and sex as an activity and reproductive functions of our body, this is a, you know, naturally occurring process and activities and ideas that are a part of pretty much everybody's lives, right? Sex is listed as one of the basic human needs. So if you really kind of think about it also, right, if we have better nutrition, if we're taking it back to basics, if we're exercising, if we're kind of doing things to keep our body well, very often that has a positive impact on our mental health. And vice versa. If we're keeping ourselves well up here, and I know it's not always that easy just to manage it on our own, but if we're keeping ourselves well up here, we know that the brain isn't disconnected from the body. So there's this kind of, you know, give and take relationship there. And again, I just like to say that I think that they swim together because we're taking care of part of our body and it's all connected. Let's see, we have a lot of really great comments. I love this. So Sarah said, I'd imagine that not only the flood of good hormones associated with orgasms, but the trust and connection that they have with another person. Yes. So when we talk about, you know, and I know you guys, ladies, we mostly have ladies here. We might have a couple guys as well. I know when you all, you know, work with individuals in the communities, one of the things that you really try to do, and sometimes it can be really hard because I find that a lot of the folks that we provide services to tend to isolate or be isolated or maybe be in neighborhoods where they can't socialize a whole lot. We want to build up that natural support system. We don't want them to have to call us all the time for everything, right? Not just for our own sake, but also we want them to not, you know, to have less anxiety, to know that they have, you know, additional individuals that they can rely on. So absolutely, that trust and connection with another person. Carolyn said back to general well-being, that psychosocial connection. And she does say, and I completely agree with you, that she views American society as having a complicated relationship with the subject of sexuality in general. The commodification of sex via advertising combined with puritanical views that prevail, yes, denial, like people aren't really having sex, create a number of challenges to healthy discussions around sex and sexuality. Absolutely, Carolyn. And I think that that's some of those kind of ingraining in that puritanical culture is some of what, and then how that manifests within our families of origin, you know, the culture, the subcultures of our own families, and what's the norm, you know, what you're allowed to talk about, what is frowned upon to talk about, all goes into like our comfortability in talking about these topics. And Sarah also says, as well as the ability to be vulnerable with an intimate partner, that may register even subconsciously that we ourselves, as well as others, can be trusted with our vulnerable selves. I love that. And Sarah, I also, so that idea of, engaging in this natural activity, that has these, like, if it's a positive relationship, kind of has these built-in behavioral reinforcers and self-esteem reinforcers and our sense of self and our sense of self-agency, right? So like, it's really risky. It is really risky to trust another person. Believe me, it takes a lot for me. And I become suspicious really, really quickly. And so like, but that ability to like be vulnerable, and whether it is love and sex or love alone or sex alone or whatever it is, the ability to be able to kind of take that risk and put one's self out there and trust another person and have it be reinforced as a positive experience really does transfer and can transfer to other goals and activities that individuals may be interested in. I don't know if you've ever worked with someone and had this experience, but I've had it for myself. One of the most difficult thing, I would say the most difficult thing that I've ever done, aside from raising a 15-year-old in my life, is losing a bunch of weight a few years ago. And I still have the last 40 that I want to lose, but I've lost 80 pounds over about the last 10 years, 9 years, 9 years, no, 10 years, 10 years. And have kind of leveled out and kept it off, been in a level place for the last 4 years. That to me, as an overweight or a kid who was called obese at 5, and now I'm 47, that was huge. And actually that gave me the courage that I felt like I needed to be able to get my dissertation done. Because I was like, if I could do that thing, which I chose to do it because I had diabetes, but it was becoming really difficult to manage. So I love people of all sizes. I think people of all sizes are beautiful. For me, it was a health decision. And it was a hard decision, right? So, or not a hard decision, a hard thing to do and to be able to manage. That was able to help me kind of like transfer that sense of I can do this. I can do things that I'm afraid of doing to another activity. Yeah, Sarah, that was a great comment. Thank you for that. And yeah, so sex with someone you trust is also a judgment-free zone, right? So if we're comfortable with ourselves, if we're comfortable with sexual activity, we're comfortable with the emotions that we're feeling, we should feel free to be able to express ourselves, express our feelings, express our physical desires and needs to that other individual or individuals. And you notice sometimes I'll correct myself there because, I also know that monogamy isn't the only way to go for folks. So, great. Thank you for that. So we talk about all that happy stuff and fun things, and pleasant emotions and that can come along with having a positive sexual relationship with another individual or individuals. Now let's talk about some of the ways in which some of the icky, not so nice stuff happens to individuals that we work with, and perhaps some of us as well. So there is this thing called sexual stigma. And you probably can see that really blatantly if you think about the ways in which individuals who may be part of the LGBTQ plus community may be stereotyped, discriminated against, in some cases outright hated, and have aggression acted upon them. Sexual stigma also occurs within other populations, and it does really get in the way of providing sexual health care and discussions about sexual health care to individuals who may be living with disabilities or potentially disabling conditions, especially those, I shouldn't say especially those. I don't want to compare that, but when we talk specifically about individuals with psychiatric conditions, there are some frequent things that we hear people say. When you think about the individuals that you serve or may have served in the past, if you can remember any discussions about the individuals in terms of having romantic relationships, dating, getting married, having sex, having children, being pregnant, whether it be things that you've heard said about folks, sometimes even things that we've thought, and I can lead with my own so others don't feel like embarrassed or put on the spot about it or like bad clinicians. What are some of the things that you've heard said about individuals with mental health conditions in and around the topic of sex and sexual activity? Now, I will start by saying that when I worked in supportive housing, I started as a case manager in 2000. And I also simultaneously worked in homeless street outreach and case management. And when I would have individuals that I worked with, and I feel that I was especially discriminatory towards women, and I think it came out of a paternalistic kind of caretaker need that I have within myself. I wanted to take care of them and I wanted no harm to come to them. And I wanted them to continue on their forward trajectory of recovery from a psychiatric condition, usually also homelessness, and probably 70 to 80% of the time also a dependence issue, with substances or process addictions. I just really wanted them to do well and get better. The farthest thing from my mind in thinking about how to help them with that is making sure that they are satisfied with their sexual health and that they are sexually healthy. And I saw sexual relationships and dating and romantic relationships as things they just shouldn't focus on right now. Like, you just moved into your apartment. How does this go, right? You just moved into your apartment. You've been homeless for a couple years. And then within a couple of months, I see a boyfriend or a girlfriend coming around. And I would panic. Let me say I would just panic. Because I think there were a couple things going on in my head. Number one, oh my gosh, how is this going to complicate my job? And forgive me, that's probably a really narcissistic thing to worry about. I was a new case manager, but at the same time, I know for a fact how hard, relationships can be, right? We've all probably had not so good romantic relationships, and how that can really stress an individual, I know myself, out. And I just didn't want anything to kind of upset the apple cart when it came to the recovery of the individuals that I was serving. So this fear that somehow having a romantic relationship where sex is involved may be somewhat problematic or negative for an individual. I was afraid it would set a person's recovery back. What about any of you? Anything that you've heard or things people say about individuals that we serve in relation to sex or sexual activity? Okay, so Sarah says that they work as a sexual assault victims advocate, and many times they hear that folks with delays or mental health issues shouldn't be allowed to have sex, or they shouldn't have children, or the surprise folks have when they find out that folks with delays or mental health issues want romantic and/or healthy sex lives. Yes. Again, remember, humans first, right? And this is one of our basic needs. Some people may choose not to engage. Some people are, identify as asexual. And for some people, sex is a huge part of their lives. For others, much less, right? But just this idea that for some reason, individuals with developmental delays, intellectual disabilities, and mental health conditions somehow just lack that, that human need, right? How dehumanizing is that? And then this idea that, And this comes from eugenics. And most of you probably know what, I think all of you probably know what eugenics are. If you don't, it's this study of, I hate to even go into it, but this idea that there are certain races and ethnicities of individuals that are stronger or less strong. And remember this kind of really, it's been happening, happened in the United States well before Nazi Germany and in other parts of the world, but we kind of saw, you know, kind of the greater public exposure and awareness of it after we learned the horrors of the Holocaust. And so that is like the sterilization of individuals that the controlling population, or those individuals with power, usually in an authoritarian regime. Sorry if apparently pollen affects my ability to speak as well. Impose upon individuals that they feel are less desirable in their population. So we saw this happen in Nazi Germany, where they tried to perpetuate their quote unquote belief that there's this Aryan race that is superior, right? And we see it happen in other parts of the world as well. So like things like forced sterilization, and this still happens to this day in parts of this world with individuals who experience intellectual developmental disabilities in addition to mental health conditions. Excuse me. So yeah, so this idea that, you know, it is a normal part of normal part of the kind of array of human needs that we have. There's also this thought process. Oh, Victoria, let me read here. I work with an aging population, and there's lots of discrimination from family to other providers related to not even wanting to consider that the client might even be masturbating is phenomenal, especially if there are other comorbidities like mental health. They become unable to make those decisions. Yes, so a little story from our state hospitals here. We had an individual on a unit that I was consulting on, which is called a positive behavioral support unit. So it was a specialized unit for anybody who needed positive behavioral reinforcements. It was especially designed for individuals who had some like really problematic aggressive behaviors where they were engaging in self-harm and also, you know, kind of striking out at others. And it was delaying their ability to progress towards discharge. One individual in that unit had some compulsive sexual behaviors. She would strip in the hallway and she would masturbate. A discussion arose in a team meeting about the purchase of a sexual aid for her. And the amount of controversy around just the discussion, let alone all of the safety issues, infection control, all of the other people who have to chime in about it. And I understand it's a hospital, but at the same time, there are individuals who literally reside in the hospital, as you all know, for years, sometimes for decades, in some of our most, you know, high acuity units where individuals have the most profound symptoms and impairments to their ability to function outside of the hospital. And so this was a topic, of course, I brought it up as a possible solution, but it would not even be entertained. And this was an individual that had already spent 10 years in this institution. Likewise, with the older adult population, there's a double stigma, right? So when you talk about things like amplified stigma because of intersectionality, these are some of the things that we're talking about. So as a society, we already exclude, or we think of our older adults as asexual. They don't desire sex, they don't want to have it, they're not able to, and they wouldn't find it pleasurable anyway, right? We kind of just discount it. I'm not saying all of you, I'm using the royal we, but then throw on top of that, perhaps a mental health condition or a delay of some kind, or even visual or auditory impairment or physical disability, and you start to layer on the stigma, right? And unfortunately, this has led to things like massive outbreaks of sexually transmitted infections in long-term care facilities because we don't want to talk about our great aunts and uncles and our grandparents and our moms and dads, you know, doing those things. And it's really a shame because it does affect quality of life. of those individuals being served, and also can make them be at risk for other complications. Great. These are some great, great, great points of feedback. I appreciate it. So, let's talk about stigma. Stigma, it serves to it's a cyclical thing, right? So we kind of have this stereotype about a population and we divide ourselves. That is them, this is us. Me good, them bad, right? Like this is kind of how that works. Creates this division. That other group that tends to have personal characteristics surrounding the group that the predominant culture finds less desirable. Doesn't mean good or bad, but the predominant culture, the culture with power, feels is less desirable and may view as bad. It results in lower social status, lowered opportunities to engage in society, and different facets within that, including socialization and the development of relationships. And for individuals that we may serve, they may kind of select out of the world of having sex and having intimate relationships or romantic relationships, approaching people that they may be interested in. Leads to discrimination. Discrimination leads to labeling. So, those really ugly and negative statements that people say about individuals with mental health conditions. And then also, this stereotyping thoughts that we may have, things like they are too sick to have sex. Having sex is going to make them worse. It's going to somehow stress them out too much and they're not going to be able to manage. What if they, realize that they have some impairments in their sexual functioning because of medication? Oh my gosh, are they going to want to stop taking their meds, right? And then we know what that might lead to, right? So there's all of these assumptions that happen. And unfortunately, I know I will say I had sexual stigma. Maybe I still hold on to it. I'm not sure. Like this is a constant kind of growth and challenging our own thoughts and assumptions that we may have around people. And so people tend to then develop this thing called an illness identity where, well, these people are calling me this thing. So when individuals are being treated in a mental health setting, maybe a not so recovery oriented mental health setting, more of a medical model, and are being talked about by their diagnosis, right? Have you ever heard that person's schizophrenic? Or in the hospitals, I've heard things like the schizophrenic over there, or that person is acting so bipolar. What does that even mean, right? So, you mean the person's mad or the person has needs that aren't getting met, so like folks get labeled and then they start to think about themselves as the illness. And so that loss of agency and the loss of self-identity as a person first, may lead individuals to thinking, why even try to have a relationship with somebody? I'm unworthy. So those low levels of worth and self-esteem that happen when one adopts an illness identity. Spoke about intersectionality. Also, this concept that people with psychiatric conditions may be considered violent. We do know that individuals with psychiatric conditions are perceived as potentially more violent, mistakenly perceived as potentially more violent than the general population, when in fact, individuals with mental health conditions, and then you throw in, many other co-occurring conditions that may be present, are much more likely to be the victims, especially of all crimes, and definitely violent crimes. And they are more likely to be victims of sexual crimes as well. Things like I said, exploitation, intimate partner violence, and so on. So, this idea that if you have heard for a long time, or if you've been treated like individuals with mental health conditions are violent, and you're told you have a mental health condition, So this idea that you may be dangerous, or that at least you are aware that other people may perceive you as dangerous, or other people may perceive you as unpredictable or too sick, quote unquote, to be able to have a relationship. It puts individuals in the position of choosing to keep that part of themselves a secret, this health condition that they manage, or disclosing that to a potential intimate partner. And that, that we talked about trust earlier and that feeling of connectedness, for a lot of individuals that I've worked with, that idea of disclosure is one of the scariest concepts to them, to think about having to tell someone that you really care about, or you may really desire, or you may be interested in getting to know, that there is this thing that's a part of your life. It is not your life. It is not who you are, but that perception is out there, right? And so being able to manage how that information is disclosed is also very similar to the experience that if you've ever attended some of our supported employment webinars, my colleague Joni Dolce talks a lot about, and I think she's writing her dissertation about this, is about that idea of disclosure and how individuals choose or don't choose to disclose that they have a psychiatric condition to potential employers, right? So we call it managing personal information. And that's a part of it, that decision to disclose or not to disclose. And this perception that might be out there that the individual is somehow flawed or lesser than, right? Again, this is a common stigmatizing belief that can be applied to multiple populations, subcultures, and individuals with, differing personal characteristics. Okay. So let's talk about some of the ways that we can help the individuals that we work with achieve sexual health, and how we can all, we're not excluded, right? We're human beings. I think I am. I'm feeling like one big pollen spore right now. I'm sorry. How we can help individuals and how we can help achieve and maintain our own sexual health. So having access to comprehensive, good quality information about sex and sexuality is a great start. So if all you're able to do moving forward in working with the individuals that you serve in the supportive housing setting or in other settings is to be able to be a conduit of information and resources, whether that's you're helping them, by going to trusted sources on the web, like the CDC or the World Health Organization, or at the end of this slideshow, and again, you'll receive this in a handout, some other online resources for some specialty professional organizations specific to sexual health. So you'll have those resources when we end today. So if all you can do is provide education, great. And with some individuals that you work with that you may have concerns around your sexual health, like let's take, for example, an individual who you may be aware has multiple sexual partners. You may or may not know if they're practicing safer sex practices, right? And maybe they don't want to talk to you about it, or maybe they admit that they're not, using prophylaxis or condoms or PrEP, which is a preventative for to help protect people against HIV infection. Maybe you're aware that they're not using anything like this, and they may be in a high risk category, or just, as a human being, we're in a risk category. You can provide information. Obviously, if you think that providing information is going to be off-putting to them, have a conversation first. And if it's still off-putting, if they don't want to talk about it, then you don't push the issue. But this is a good first step. And this is a great way to kind of start to broach the subject with, any of the individuals that you work with that you may think that this is a consideration, is to just simply provide information. To provide knowledge to help people understand what are the risks faced and some of the vulnerabilities to the adverse consequences of unprotected sexual activity. So we know with this population, I've said it a couple times already, they're at higher risk for sexually transmitted infections. and diseases that could affect the reproductive system and systemically. HIV/AIDS, HPV, which is human papillomavirus. Human papillomavirus itself, a lot of people downplay it. I think the current estimate is that almost 60% of the population has it, the American population. I'm not sure, it might be slightly lower, slightly higher, but that was the approximate last figure that I saw. And so that means that if one is having sex, they should assume that their partner might have something, unless everybody's been tested, right? And even then, if you're in a new, that test is only as good as the day that it was taken. So this idea that, things like genital herpes have at times been downplayed, but they can lead to certain cancers of the reproductive system, and also more frequently in men, of the throat, of the mouth, and of the throat. In women, it can lead to uterine cancer, cervical cancer, I'm sorry, primarily cervical cancer, not uterine cancer. The ability to access sexual health care. So the individuals that we serve should be able to feel comfortable talking to their healthcare provider about sex, about, symptoms that they may be having, whether it's low sexual desire, whether it's problems with orgasm, whether it's erectile dysfunction, or whether it is some of these things, they may think that they have an infection or some kind of, negative consequence. So that ability to access competent, comprehensive sexual health care. So for some individuals, this may be a little bit more difficult than others. I know that in Washington, you have some, the frontier areas where there may not be as many overall healthcare services. And in addition to, when we talk about sexually specific, the offerings, the availability may be even less. So helping people access that, and helping people to feel comfortable talking about their issues, their needs, their desires, their problems with their healthcare provider. And we can do that by helping to do role playing, right? If a person wants to talk to their doctor about birth control, or wants to talk to their doctor about some symptoms that they may be having, if they feel comfortable, if you have the rapport with them, they may be able to role play some of those conversations with you. Okay, and also residing or living, thriving in an environment that affirms and promotes sexual health. So, having those people around you, having supports around you, that you can form that positive relationship and for emotional support, spiritual support, direct support in accessing sexual health care. And also living in an environment where one feels safe to be able to socialize and meet others, right? So one of the goals of supportive housing is that people are integrated into their community, that they achieve maximum community integration. When people are afraid to go outside because they're living in a high crime area, or where they may feel targeted because of their gender or gender identity, or their other aspects of their sexuality, that is not affirming and safe, right? So we want to try to help people feel safe in their environment of choice. We also have to help manage the risk. And this is the area I say these are the things that I like to talk less about. I like to talk about the positive aspects of sexual health and how it relates to psychiatric recovery. But these are some of the things here that can really lead to devastating consequences in people's lives, and also devastating emotional consequences in addition to physical. So we've already talked about sexually transmitted infections, so I'm not going to talk about that too much, other than to say that you see here RTI, that is reproductive tract infection, or reproductive tract infections, I believe. So these are diseases of the reproductive system, and so some bacteria, some viruses can cause, especially in women, problems and scarring in their uterus. They can have pelvic health issues, also. And so these are other issues that could crop up that you should be aware of. Sexual dysfunction. This is probably what I'm going to spend my most time talking on this slide, and that is, I'm sure you've seen a lot of commercials for the little blue pill. I'm sure there's different color pills now, but like for Viagra and Cialis, and I think there may be others out there. One of you, I'm going to look back. Victoria had spoke about working with the aging population. And so in one study that I read, and this one was out of Canada, it was a study of about 160 individuals who were taking antidepressant medications for the treatment of clinical recurrent depression. All were over the age of 65 and were considered, therefore, in the older adult geriatric population. And the study was what predicts medication compliance. So what helps keep people on their medications and functioning as well as they can if medications are kind of a part of their treatment regimen? So we looked at what explanations do people give to their providers when they stop taking their meds? For the majority, for men over the age of 65, the number one reason was erectile dysfunction or problems with libido/desire, sexual desire. So that ability not to be able to gain or maintain an erection, or the inability to orgasm for men was the number one reason over the age of 65. So again, for anyone who thinks that our older adults aren't having sex, or aren't masturbating or don't want to, you're wrong. They do. And so, when we think about the role that we play and wanting to keep people well and moving forward in their recovery and hopefully moving on to bigger goals, like maybe returning to work or developing relationships, going back to school, volunteering, if folks function better on their medications, we probably want to encourage them to, keep that as part of their lives as long as they want it and they're not experiencing harmful side effects or distressing side effects. But when people experience distressing side effects, especially ones that they feel like are difficult or uncomfortable to have conversations around, you may see people stop taking their medications and just think, oh, see, this happens every time. This is what I used to say. It happens every time. You get 6 months in and you're doing really, really well, and then you stop taking your meds and we're back to crisis and we're back to the hospital, right? Without really asking the why questions. And maybe even if I did, I don't know that the person, especially with my presentation when I was younger and in the field, I don't know that if they'd feel like I was open enough and trustworthy enough to talk to them about it, right? So we want to make sure that the individuals that we serve, if they're on any kind of medication, especially psychotropic medications, that they know that these might have sexual side effects. One of the reasons that healthcare providers, especially those in the medical field, so we're talking like psychiatric nurses, and psychiatrists, one of the number one reasons that they have for not disclosing to their patients, I'm just going to use that word because we're talking about the medical relationship. One of the reasons they have for not disclosing that information to the individuals that they're prescribing to is for fear that the person won't take the medicine. Instead of helping them be prepared to know that, hey, this is a possibility. And if this happens, give us a call, come back in. There's probably something we could do about it. We could talk about different formulation of the medication, maybe a different dosage once you're feeling a little bit more, kind of stabilized. Maybe we could talk about, again, Cialis, Viagra. And I should say men aren't alone in this. A great deal of women, in one study of SSRIs, it was the majority of female individuals asked reported low libido or other sexual side effects as a consequence of taking the SSRI medications, which are probably the most frequently prescribed antidepressants, and they also cross over and also treat Anxiety disorders as well, like Lexapro and Celexa tend to be especially effective at treating both conditions, especially generalized anxiety disorder. So, we need to be proactive and tell people that this might happen. And so when you're working with individuals who may be new to taking medications, or maybe having a medication change, or maybe they haven't had a change to their medications in a long time, when you're checking in with them about how they're feeling around their medications and on their medications, this is something you might want to just kind of drop in there, right? Like, oh, I see you're on blah, blah, blah. There's a risk for, you could list several side effects and stick that sexual one in there to kind of soften the blow a little bit, but just to kind of open the door. Again, providing education. You don't have to have a big old, physiological medical conversation about it. You don't have to pry too much. Just drop that information out there. This is something you may or may not experience. Other people have experienced this, that take this medication, and there are ways that we can manage it. And if you're not sure, let me know and I can help you talk to your prescriber, right? So you just want to open that communication up. Also, I touched on sexual and I always want to say interpersonal violence, because that's another world that I live in with the hospitals, but intimate partner violence is at a greater risk in this population that we serve as compared to the general population. And we want to make them aware of things like this doesn't happen as frequently in this country, but we do see it occasionally in subpopulations, subcultures, and that is this idea of female genital mutilation. Again, we don't see it an awful lot in our country. In other countries, you may see it gladly. Luckily, this practice is declining, but this happens most often with women, with female children, very often around the time of puberty, where the clitoris is removed, so that the female cannot experience sexual pleasure. In some other cultures, other things are done, and I'm not going to go into it because it's not a comfortable conversation. We're not going to go there. But again, if you have if you have individuals that you're working with, and this is not to say that, again, I say that this is a rare thing in the United States, but it helps to understand cultures and be culturally competent around the cultures of the individuals that you're serving, right? So it's important to not only know if those kinds of things are kind of in a part of, a culture or a culture in years past, but it may be something that is a memory in the family. Those kinds of things can cause generational trauma. Additionally, the ways in which there are differences in how the genders are treated in different cultures. I mean, the United States isn't perfect, right? And we talked about kind of the puritanical approach in the United States. As a side note, in my dissertation, most of my literature that I've read, most of the studies that I've read, where sex and its interface with the individuals who may have psychiatric conditions are concerned, most of that research is being done outside of the United States. And I venture to guess it is because Europe and Asia and even the Middle East, which sometimes we think of as more conservative, there's more research coming out of those parts of the world than there is the United States. And I fully believe it's because of our cultural beliefs around sex and sexuality. Okay. So we talked about that spoiled identity. And so one of the things that individuals who are receiving services say to us is that they want us to talk to them about them as a whole, talk to them about their needs as a whole person, and not just related to, their condition of schizophrenia or their condition of bipolar disorder or recurrent depression. They want to be seen as a whole person, just like all of us do, right? So, to have that focus on wholeness and integration of self. And as we, talked about earlier, sexual health is so closely related to our overall wellness and psychiatric recovery. For those of us who are recovering from psychiatric conditions, that it makes sense to want to talk about it and want to make sure that we can ensure individuals have the healthiest sexual experience that they can have. So what is your role in supportive housing, other than being a hero and constantly saving the day and putting out numerous fires throughout your day, your week? And I know Friday is tomorrow, so I'm sure you'll have a few tomorrow afternoon. Your role around sexual health is really no different than it is around other aspects of an individual's life or other aspects of their kind of domains of wellness, right? We talk about things like vocational domains and educational domains and physical health domains and spirituality and so on. This would fit it. I like to say that sexual health kind of overlaps a lot of them, right? Because if you're not working, or if you feel like your income is really low, if you have low self-confidence, if you're over-identifying with your mental health condition and thinking of yourself as a quote unquote patient, or somebody who is lesser than, it's probably going to be harder to engage in relationships with other people because you don't feel so great about yourself, right? So this idea of sexual health kind of overlaps in a lot of those different categories, and I don't feel it only lives in our emotional and physical health domains. So your role is to do what you would do if you had an individual who had a goal to, go back to work or go back to school, and that is to ask questions, right? Be inquisitive. And in the second part, we're going to kind of talk about some structured ways to have those conversations. Especially if just starting to talk to folks about sexual health, it really helps to have a framework and a structure. And so one of the frameworks that I like to use is motivational interviewing. If you attended, or if you've been around for the last year, you've probably seen motivational interviewing trainings fairly regularly advertised from us. And so I would encourage you to sign up for the next one. But also, sorry, just check the chat. Not a problem, Carolyn. Thank you for your input. Hope I see you next week. But to use some structured frameworks for having those conversations. There's others out there, and I'm not saying motivational interviewing is the only one, but be inquisitive, ask questions, ask, so are you seeing anyone? It doesn't have to be, are you having sex? Do you have any friends? We could start there and kind of work our way down the funnel or up the pyramid, I guess. Identify unmet needs, again, as you would with any need or problem that the individual or desire that they might be having to work on in their life. What are the unmet needs? Oh, you've never had a sexual infection screen. You've never had blood work done, or you've never had a gynecology exam. So many of the women that I worked with in supportive housing, I can't tell you how many were in their 30s and had never had a gynecological exam. I can't tell you how many women that I worked with delivered babies and only saw an obstetrician once or twice, if even that, during their pregnancies. And so, having those conversations, even just from a purely medical, like just covering all bases and checking down the list of all the different doctors and systems that you have within your body, just bringing that up. When was the last time you saw a gynecologist? Establishing goals around there and identifying, who's going to be responsible for what. Again, I know that all individuals that we serve don't have the same set of same skill sets, so you may need to help some folks more than you do others, but establishing goals and the roles of yourself, their medical provider or other provider, and what roles the individual will play. Educate and link to services. Again, educate. If you don't know what else to do, you can't go wrong with providing education. And it's great to be able to document that in your progress notes, your clinical chart, that, you identified that this thing may be an issue and you provided them with education. That's an intervention. That is an intervention, right? It's a clinical intervention and you provided it. and or help link to services. You know, sometimes people will say, I don't want to talk to you about this, but I'll call XYZ Reproductive Center. That's fine, you know, you could always revisit it in the future, but that's quite all right. And also, as you do every day, all day, every day, in and out of work, to advocate, advocate, advocate. So in the reference section or the resource section, I'm not sure what I named it, of this presentation, you will have the links for all of these professional organizations. The American Sexual Health Association, the American Public Health Association, which is a great, has a great website on all things public health, and they do have a section that focuses on sexual health. CDC has some great information, handouts, pamphlets, brochures, things that you could actually just print out and provide to people. There's also something called Sexual Health TV, which is, I believe, part of the World Health Organization's website. And so there will be a link to that. So they have educational videos, and I believe in different languages. So you could, if somebody has concerns about something, you know, if they have their own device, you can give them a link to watch it in the privacy of their own residence. If you want to watch a video with them and then have a discussion about it. If you wanted to do this with a group of people, I know some programs offer group services and things like that. You could do that as well. So really some great practical resources. And these are resources that I tend to go back to every couple of weeks as I'm working in this world, to verify information and check on updated information. So a couple other things that I just wanted to talk about. One of the other areas that folks providing services, so folks like you and me previously, tend to say when asked, do you talk to people about their sexuality or sexual health? And they say no. One of the leading reasons as to why, actually in 2 of the studies that I read, it was the leading reason, was that the providers were afraid of busting any boundaries, of crossing any lines in having these kinds of conversations within the therapeutic helping relationship, right? So feeling as if talking about sex and sexuality is somehow bad. And that is what has been, we've been kind of indoctrinated to think that way in a lot of ways. I think that folks who are much younger than me maybe have less of that, but I'm almost 50. So I had a lot to unlearn as I got older and went into this area of research. But like, we feel uncomfortable. We just do. A lot of us do. And so it takes practicing these conversations and maybe even finding, like, if you have a special interest in sexual health and really trying to make a difference in the sexual health of the individuals that your program serves, that your organization serves, you know, partnering up with somebody else who may also be interested in the same, right? Getting some of that support and kind of bouncing ideas off of can be really helpful. Okay, so we have about 7 minutes left. So I want to pause here for a couple minutes and see if anybody has any questions before we wrap up. Well, first I have to read this slide, but I'm going to start to read the slide. And if you have any questions, please feel free to type it in the chat and I'll come back to it in a minute. So in wrapping up, we just want to say thank you. We appreciate your time, attention, and participation. As you know, this presentation was hosted by Washington's DBHR through the Healthcare Authority. We'd like to remind you that the slides, a recording of the presentation, and any accompanying resources will be available in a follow-up email, which you should receive tomorrow. Don't forget to check out Washington's Foundational Community Supports newsletter for all the great FCS information and news and any upcoming training events. And if you'd like to become an FCS provider, you can reach out to AmeriHealth at the number listed on the screen. This is just a little advertisement for my team's website at Rutgers. So you'll see here, unfortunately, I left the old slide in. State Hospital Psychiatric Rehabilitation Initiative. We're now called the Institute for Inpatient Psychiatric Rehabilitation, but the website, which you see on that screen, underneath the picture of our university there, is still the same. So you can use that link. We have a lot of free resources, a lot of training videos there that are all free of charge. We also have our own YouTube channel, which you can access through our website, or just by going to YouTube and typing in SHPRI Rutgers. Oh, Jen was not here today, but here is my contact information. If you have any follow-up questions or comments or feedback that you think of following this training, you can feel free to email me here at the email on the slide. And again, it'll be in the handout. Here are your references and resources. And that is it. I see no additional questions. So with that, we're going to go ahead and wrap up. Again, as a reminder, part 2 of this webinar will be held next Thursday at the same time, 1 o'clock your time. Will also last for about an hour and a half. I will see you next week, Sarah. Thank you so much. Thank you everyone for your participation. I hope you enjoy the rest of your day and happy summer. Thank you all.